So Rowan, I think over to you when you're ready. Rowan, can you hear me? Rowan, I think we're ready to start when you are. And Rowan, if you're speaking, we can't hear you, or at least I can.
I think in Kenya, we're just having a few Wi-Fi issues because of the protests. Let me just reach out to Rowan to see if we can hear. Can you hear me?
Hi, Rowan. I don't know if folks can hear you. Can anyone else confirm that they're having issues hearing?
Can anyone hear me?
Kawal, yes, I can hear you.
Yeah, so I think we're just having some Wi-Fi issues in Kenya because of the protests. Let me just reach out to him directly and see what the issue is.
Great. Thank you all for your patience.
Am I audible at all?
Now you are, yes.
Okay, so I suppose no one could hear me from the start of the presentation.
No, I don't think so. Sorry.
Okay, well, I will restart then.
Perfect.
Okay, well, everybody, thank you for bearing with the technical difficulties. Today's webinar is meant to showcase a playbook that Busara and Path have worked diligently to create over the course of nearly 2 years of collaboration. Today, my team and I will present a bit of background on the Drive Demand project, as well as some information about us, Busara, before diving into the structure, function, and purpose of our playbook. My name is Rowan, and I'm joined by my colleagues Kawal and Janet, who will be presenting specific sections. We represent a portion of the Busara team that has contributed to this work, which includes a team of 8 staff working across sub-Saharan Africa, as well as a number of data collection partners and teams whose work was invaluable to support our research. I'll pause here and ask again, am I still audible?
Yes, we can hear you.
Perfect. Our research has been conducted as part of a larger initiative entitled the Digital Results Improve Vaccine Equity and Demand Project. We'll refer to that as the Drive Demand Project throughout this presentation. Drive Demand is a 2-year partnership with Path's Digital Square Initiative and the Rockefeller Foundation in order to deploy and expand the use of digital health tools in Honduras, Mali, Tanzania, Thailand, Uganda, and Zambia. Drive Demand aims to help ministries of health and its partners to utilize digital technologies to understand, track, and influence demand for immunizations. It supported countries to reach COVID-19 and routine immunization targets while strengthening data-driven health systems in Asia, Latin America, and sub-Saharan Africa. Now, as part of Drive Demand's larger objectives, we were commissioned to conduct social and behavioral research to understand the barriers and drivers for routine immunization and COVID-19 vaccination. We developed a joint research agenda with the PATH team, including questions and methodological approach, with the overall objective of producing insightful, action-oriented resources for public health practitioners to understand and respond to vaccine hesitancy. We call this the Practitioner's Playbook, and this is the bulk of what we'll be presenting today and what we are launching today. Now, before we begin, I want to start with a brief introduction of Busara, our organization, in case any of you are unfamiliar with us. We are a behavioral research, design, and advisory nonprofit headquartered in Nairobi, Kenya, and with operations across the Global South. We apply and advance behavioral science and human-centered design approaches in a bid to alleviate poverty. This slide here represents our 4 core objectives in our current strategy, which is to be boutique and pursuing projects and partners that we believe in, to be cutting edge, using methods that we think are innovative and pushing the frontiers of behavioral science, to be vocal by emphasizing the role and importance of the Global South in the center of our research, policy, and practice, and to build an ecosystem of similarly minded actors applying and advancing behavioral sciences. To date, I think we're just over 150 staff these days. We've completed over 500 behavioral advisory projects across over 45 countries, and we maintain 3 decision labs. Here are our presences. We have sub-Saharan offices in Ethiopia, Nigeria, Uganda, Tanzania, and our headquarters in Kenya. We maintain a permanent office in India and have a hub of staff and projects across Latin America. With that, I'll hand it over to my colleague Kawal to take us through the findings of our research.
Sure.
Kawal, over to you.
Thanks for the introduction. I'm going to be taking you through the background and structure of our research. So this is just going to be a study background, a slight overview. So we were brought on board by PAL's Digital Square initiative in order to help better understand the social and behavioral dynamics of vaccine hesitancy and uptake. So like the broader Drive Demand project, our work was initially focused on the COVID-19 vaccine uptake. However, with a lot of reflections and guidance, we adjusted our tool to include questions that captured dynamics of routine immunizations as well. So our research was guided by the global team, and we examined 3 different study groups. So the first was unvaccinated pregnant women, second was unvaccinated adults, and the last was community health workers. And so this research was initially intended to cover all of the drive and demand countries. However, our work eventually came to focus on 4 main African countries, which included Tanzania, Mali, Uganda, and Zambia. So our research objectives, they reflect on the ambitions of the broader Drive Demand project and also have attempted to capture the ambitions of each country's program. So as you can see, our first objective is to compile global and country-specific research to understand vaccine hesitancy and acceptance. The second is to develop adaptable guidelines for local health authorities to identify vaccination barriers and use digital tools to reach people. And finally, our third objective is to share evidence to scale up best practices and guide decisions by donors and health ministries. And so with these objectives, we developed 6 research questions. So these questions were mainly looking at exploring the factors that influence vaccine hesitancy and acceptance. This includes how information and messaging about COVID-19 vaccines shape attitudes and behaviors as a whole. We were also looking into how risk perceptions, both COVID-19 transmission and severity, as well as potential vaccine side effects. So what impacts people's decision to get vaccinated? Another focus that we had is identifying key social and behavioral change communication messages that drive vaccine demand and uptake. So this also focuses on determining which digital platforms effectively spread accurate information about health in order to achieve positive social behavior change. And lastly, we were also investigating how the delivery of COVID-19 vaccines affects routine immunizations. So now I just wanted to take you through a short explanation of the structure of our study and also the theoretical framework that we use to design our research. So our research was structured broadly across 4 different stages. The first one was the evidence review. So we evaluated global literature on vaccine hesitancy with a particular emphasis on vaccine hesitancy for the COVID-19 pandemic and with evidence from low and middle income countries. So we eventually published this evidence review, and you can find this online, but I'll just take you through the 4 stages. In stage 2, we used our takeaways from the review to design our study. And so here is where we use the COMBI model, which I'll come to later. And this model was used for understanding and designing for behavior change as the guiding framework for our study. And we selected barriers from the literature that thought we most relevant for further investigation. In this third stage, which is the study implementation, we, in close partnership with the country teams, we completed 3 focus group discussions with each of the study countries. And in stage 4, we conducted the analysis of the data from these focus group discussions in order to develop the playbook that we'll take you through to enable the vaccine intention creation for these different segments. So as mentioned previously, the COMBI model was used, and I just want to take you through a brief summary of what the COMBI model is exactly. So COMBI stands for capability, opportunity, motivation, and behavior. So basically, behavior changes require 3 components: capability, opportunity, and motivation. So capability involves both physical skills and psychological factors like knowledge, cognitive abilities, and behavioral regulation needed to perform a certain behavior. Opportunity encompasses physical and social factors. So physical opportunity refer to environmental resources and situational factors, whereas social opportunity involves interpersonal influences with one's network. And lastly, motivation. This is mainly reflective, or can be reflective, driven by beliefs, intentions, and perceptions of consequences. So it can be automatic, influenced by desires, impulses, or emotions. So in a nutshell, the model just helps us understand and enhance individuals' readiness and ability to adopt new behaviors effectively. So using this model, we completed the focus group discussions, which included 2 components. So the first component was card sorting, and the second was a discussion. So the card sorting game is where we asked participants to rank the barriers that they believed more salient for the lack of vaccination. So when we mean ranking indicators or ranking barriers, we mean that we developed phrases that affirmed specific barriers to vaccination. For example, one of the barriers included was the health clinic was too far away from home, or one other barrier was I do not make decisions on whether people in my household are vaccinated. And so these phrases were all printed out on cards, and participants were asked to sort them out in accordance with which are the most important and the least important according to them. The second part of the focus group discussion is where we just had a general discussion with the participants about vaccine uptake and hesitancy. And so it also just probed into the dynamics of a particular focus on COVID-19 and how it also affects routine immunizations as well. So that is a brief overview of the study, and I am going to hand it over to Janet, who will, I missed a slide there. So the study timeline. So our team conducted this in February, which ended in April as well. So it took around 3 months for us to conduct this study, and it included 146 participants across all 4 countries. And so a little breakdown is there were 43 unvaccinated pregnant women included. There were 48 unvaccinated adults, 45 community health workers, and only in Mali did we interview 10 parents of children aged 0 to 23 months old. So these are the collective demographics of the participants that we interviewed. So now, sorry about that, I'd like to hand it over to Janet.
Thank you so much, Kaval, for taking us through the study background and structure of our research. In this section of the presentation, I will take you through portions of the playbook, how we developed the playbook, and how this may be useful for you in your research. Of course, it's at a very high level, so we encourage you to go through the playbook once it's released to get more detailed information. Next slide. So first, we are going to start on the function and the purpose of this playbook. This playbook is a culmination of Busara's work under the Drive Demand project, which had the intention of having actionable recommendations and tools that would be useful for ministries and other implementing partners in tackling vaccine hesitancy and non-intention. So when we were developing the playbook, we hoped that it would achieve the following objectives: aid in gaining an understanding of the typical dimensions of vaccine hesitancy and be aware of the cognitive levers when developing a social behavior change response. Number 2 is aid in the identification of study target population, so we can develop more targeted behavior change campaigns. And number 3 is to support evidence-based SPC-informed messaging, so that we can move beyond barrier identification and trigger improved vaccine uptake. So these are the aims that we had in mind when we were designing this playbook. And the playbook is structured in the following way. It starts with an overview of our findings, and this is framed around the capability, opportunity, and motivation model, as highlighted by my colleague Kaval. So this particular section covers the key barriers affecting behavioral intention to get the vaccine, as well as the facilitators of this vaccine intention. After that, we then cover 3 key segments that we formed under the drive demand research, which was qualitative. The 3 key segments that we did uncover is the vaccine critic, the differential actor, and the disempowered actor. We will go into detail in describing and understanding each of this segment group in the particular slides. And lastly, within this structure is a practical diagnostic framework that we have designed for users to conduct their own segmentation. So the framework that we have includes a vaccine intention questionnaire and a diagnostic tool. And this we will also delve deeper into the subsequent slides. So before we move to the content of the playbook, we want to highlight 2 important caveats that we feel are necessary before we show the actual content, and one is on contextualization. When we were designing the playbook, the primary goal was to provide a framework to analyze and understand why certain individuals within a community or population remain hesitant or decide not to get vaccinated. And these findings are based upon a culmination of 4 countries, and we had like 13 different respondent groups. So from this group, we had a diverse and comprehensive data set. So while we tried to be very within our selection criteria to identify key groups or key individuals, we feel like there's need to flag on contextualization because, well, some of our findings may be applicable. Some of them we feel need to be adapted to fit local contexts. Number 2 is that the playbook is concerned with the dynamics of vaccine intention, so that it does not therefore provide guidance on how to bridge the action intention gap for individuals who seek vaccination. So as such, we have only focused on the behavioral and non-structural barriers to vaccination throughout the playbook. We shall now then proceed to the playbook content and delve deeper into the segment groups that we got. When developing the playbook, it was important that we segment the audience, and these are the following reasons why we thought it would be best to segment. One is on targeted marketing. Through segmentation and learning the different groups, we feel like this will allow for more targeted market, because a one size fits all approach is often less effective. Therefore, targeted marketing is crucial for addressing the unique concerns and the motivations for each groups, as the needs are very different. Number 2 is to improve our research. By segmenting, we allow for a deeper focus, and we zoom into the different groups so that we can understand their needs. And this also contributes to more effective communication strategies. Number 3 is to build an understanding. Well, when we have the different groups, we can be able to understand very well the specific needs, and also all these have a bearing when we're developing messaging and marketing. So we are going to be more targeted as we have a better understanding of these particular groups. And number 4 is to increase empathy. By segmenting, we feel like practitioners and implementers can be more considerate and effective, and more considerate for the different groups and needs. And this often results into designing more effective strategies in building that intention for the different groups. As now you have a better understanding, you can empathize with the groups and tailor your approach to suit the different segments. So therefore, when we noted that these are the key motivators, we then followed the following process of segmentation. So first, we unpacked the behaviors of the vaccine hesitant individuals, and this data we got from the study we conducted, the Drive Demand project that was done in the 4 countries. So we thoroughly understood, we started by understanding the behaviors of those who are hesitant about vaccines. And this we involved analyzing their concerns and trying to get a better understanding of their patterns in decision making. And once we unpacked this behavior, we drew differentiating lines between the profiles. So within these particular groups, we found clear lines on the attitudes and their motivators, so that we can get a better opportunity to understand their unique characteristics. So once we drew these lines, we then identified the motivators, barriers, attitudes, and social influences for these different groups. This step was very crucial in trying to define strategies, because we realized each group was very different in terms of the specific barriers that were affecting them, the specific motivators that were driving them to not get vaccinated. So by then identifying these specific barriers, we were able to brainstorm and look for strategies that are specific and tailored for each group. So based on our segmentation process that I have taken you through, we ended up with the 3 different groups, and that's the vaccine critic, who we are going to talk more about, and they're distinguished by their strong negative attitudes and perceptions towards vaccination. And the second segment is the differential actor, and these are distinguished by their neutral or positive attitude towards vaccination. And number 3, we have the disempowered, who are distinguished by their positive or neutral attitude towards vaccination and their low perceived opportunity to be vaccinated. So we shall now tackle each group now, and my colleague Rowan will take you through this section. Thank you.
Thanks, Janet. Thanks, Kawal. So our first segment, the vaccine critic, has distinctly negative views of vaccination. This is regardless of their opportunity to access vaccine services. Their low attitudes towards vaccines preclude them from seeking services. We identified a number of specific barriers to intention for this segment, including the false consensus effect and the illusory truth effect. And for each of these, we have provided some targeted guidance on addressing these barriers, including specific SPC messaging that we think should be contextualized to everyone's context when trying to understand and respond to and inspire intention to uptake vaccines. You'll have to read the playbook to understand all of them. I'll highlight one in particular here, which is the illusory truth effect. The illusory truth effect is a phenomenon in psychology that states that the more a person is exposed to misinformation, the more likely it is that they are to believe it. And so we found that the vaccine critic, or the people who would fall into the segment of vaccine critic, have been exposed to a lot of misinformation from online and offline sources. And that confusing information ecosystem led them to lean towards misinformation or misinformed beliefs around vaccines. So in order to address this issue, we've provided a sample of 5 messages that pre-bunk and debunk myths that respond to specific fallacies, including the illusory truth effect or other cognitive distortions that exist. Our second segment is the deferential actor. This segment is characterized by neutral or positive attitudes towards vaccines and neutral or positive attitudes to access vaccine services. The deferential actor does not have strong negative opinions about vaccines, and they're generally amenable to such services. However, they do not seek them out, and they do not find them important. This segment may suffer from a number of clear barriers influencing their decision to uptake vaccines. We've highlighted a number of these in the playbook as well, but to specify one in particular, this segment may consider that traditional remedies are sufficient to prevent any illness from a vaccine-preventable disease, and therefore they do not need to seek vaccine services or feel no need to do so. In order to address this barrier, we recommend messaging that emphasizes the complementarity of traditional medicines and vaccinations. For example, a message that we provide in the playbook is that vaccines reduce the severity of the virus and traditional remedies help with mild symptoms. The third and final segment in our playbook is the disempowered actor. For the disempowered actor, they have a very low opportunity to access vaccines regardless of their attitudes. Social or physical constraints on the disempowered actor limit their capacity to seek such services. And in our research, we found often that this was driven by the decision-making process of the household and the role of the head of household, who typically was a male, in health-seeking behavior decisions. So in particular, we found that male household heads had more power to decide on whether their wives or their children or the members of their family who were in their home had access to vaccination services. And therefore, we recommend a number of male or head of household targeted SBC interventions, appealing to the authority of community figures, as well as the social influence of identity. So for example, messaging here might emphasize on the dynamic of social identity, that strong men protect their families and communities when they get their child vaccinated. So when developing our playbook, we wanted to ensure that this research would actually be meaningfully applied to the work of public health practitioners, governments, and implementing partners. And to this end, we created a diagnostic framework that we believe will allow any users of this playbook to screen and categorize respondents into each of these segments. Our diagnostic framework includes two components. First, we created a 14-question vaccine intention questionnaire. This questionnaire can be used as a standalone survey to screen individuals, or it can be infused within a larger survey to categorize a broader number of respondents. The second component of our diagnostic framework is a diagnostic tool. This is intended to help interpret the findings from the intention questionnaire. So the first feeds into the second. To develop this framework, we adapted validated measures of vaccine hesitancy. And we made reference to a scale called the 5 Cs, Antecedents for Vaccine Hesitancy and Uptake, which was published by Cornelia Betsch and a number of other authors in 2018. The questionnaire is structured with 3 sections. First, we screen for vaccine intention. If a respondent demonstrates an intention for vaccination, then they do not receive the remaining sections of the survey. But if a respondent demonstrates a non-intention for a specific vaccine, then they are asked the remaining questions. Section 2 queries into respondents' attitudes towards a vaccine using a Likert scale questionnaire with responses ranked from 1 to 7 in terms of how much a person agrees with or disagrees with a statement. Section 3 queries into perceived opportunity for vaccination, which is also measured using the same Likert scale questionnaire. In order to categorize respondents into each segment highlighted in this playbook, we created an index to categorize responses into low, neutral, and high for both attitudes and opportunities. We represented the relationships between opportunity and attitude in this matrix you can see on the screen. So for example, you can see, given our categorization, the vaccine critic segments takes the spots that have negative attitudes across the board, because regardless of the person's opportunity to access vaccine services, we found that negative attitudes were always going to decide whether or not someone had intention to seek vaccination. Likewise, you can see how we categorized the rest of the segments in our group. So for example, neutral opportunity and neutral or positive attitudes, as well as high opportunity, will categorize the deferential actor. So in our playbook, we lay out really clearly how to apply this framework. We outline 4 basic steps for applying and understanding our diagnostic framework. So first, we recommend you choose which vaccine that you want to test for intention. Our research, as well as a host of research in the literature, indicate that vaccine intention and vaccine hesitancy can vary across specific vaccines. As such, in our questionnaire, we've indicated specific points where you can insert the name of a vaccine so that you can ask specifically for those. You can still use this tool more generally to understand attitudes towards vaccinations more generally, but we recommend that you pick a specific vaccine to include in the questionnaire. The second step to applying our framework is to contextualize it. As we laid out in the caveats of this playbook, it's important that things be contextualized to whatever community or country context that you're rolling out this framework. So we recommend your instrument is translated into appropriate languages for each respondent, and that you pilot the instrument to ensure that the questions are well understood and that the responses are making sense. The third step to applying our framework is, of course, to administer the questionnaire. Again, we recommend that you can do this both on a standalone basis, using the questionnaire alone to screen respondents, but you can also incorporate it within a larger survey exercise to categorize a broader group of people into each of these segments. And then finally, you can input the responses from your survey into our diagnostic tool. So our diagnostic tool is an Excel spreadsheet where you input responses from each survey respondent into their respective category. And in the survey tool, we have entitled each of the questions with the same indicators that you see here, the same titles that you see here, where you have attitude 1, attitude 3, so on and so forth, opportunity 1, opportunity 2, so on and so forth. And we've created a simple formula that categorizes attitude score and opportunity score to let you know if their respondent falls into negative attitudes or negative opportunities. And then we've created another small, simple formula to categorize the responses and categorize the scores into the various segments. So here, for example, you can see that the first example respondent here has negative attitudes towards vaccines and a high opportunity towards accessing vaccine services, and they fall into the vaccine critic or the anti-vaxxer segments. And that reaches the conclusion of our webinar. So I'll pause here and see if there are any questions amongst the people in the group. Tori, is there a preferred way to go about soliciting questions?
Yes, I see Eileen has their hand raised. So Eileen, please go ahead.
Hello, everybody, and thanks for the presentation. I just was struck by the sample size across 4 countries, and it does seem like you've gleaned some insights, but are there plans to validate the findings or the playbook with a broader sample? Thanks.
Yeah, I mean, for us, the point was to try and draw rough generalizability across context, or rather comparison across context or country context. There wasn't enough financing available to do a rigorous representative survey to validate these measures, or to validate the findings of our survey. And I don't believe that there is currently a plan to do so. to help, I think, alleviate some of those challenges or shortcomings of the research. That's why we have leaned on the 5C antecedents as a scale for our questionnaire and for the diagnostic process.
Okay, thanks.
And Rowan, I'm going to read out a message from the chat. It says that they are not quite clear. Does this mean you have to ask the person to ascertain their level of hesitancy using the tool first? Or could you elaborate a little bit on how they could use this tool as a programmer?
Yeah, sure thing. Great question. I'm wondering if I can share a copy of the playbook. Yes. So the playbook is live and it's on our website. You're more than welcome to read through it now, even if you have questions about specific sections, or reach out to us over email if you have any further ones. So in the first annex of the playbook, we outline the questionnaire that you can use. So you can see here the code and the question and the response options and the skip logic. Yeah. And followed through now attitudes, opportunities until the end of the survey. So we recommend that you administer this survey directly with a respondent, inputting each of their responses according to the Likert scale, and then input those responses now into the diagnostic tool. So for example, you can see, so for example, you can see 1 is strongly disagree and 7 is strongly agree within our scale. So if you were to ask someone attitude 1, I am completely confident that vaccinations are safe, you can enter a 1 to a 7. And then that response will be inputted into the diagnostic tool, which I believe should be, anyways, it's in the, where is it? Right. So it's an Excel sheet, and there's a link in this playbook that allows you to download this Excel sheet. So you can see the question for attitude 1, the response here was 1, right? So you do the same for each of the questions so that you can get an attitude and opportunity score. I hope that that clarifies.
Thanks, Rowan. And another question in the chat. This person's wondering, would like to learn a little bit more about how you developed the questions in the survey. For example, were they adapted from other behavioral questionnaires regarding vaccine intentions or so on?
Yeah, thanks, Katie. So for this survey, or for the vaccine questionnaire, this was developed, I suppose we haven't cited it here clearly. This was developed upon our reading of some of the literature around vaccine hesitancy and different scales and measures for capturing intention in particular. So we started by reviewing the theory of planned behavior, as well as the health behavior model, in order to find different scales that made reference to specifically the process of intention creation. And then we've stumbled across this paper, the 5C antecedents of vaccine uptake. And it became, even in the paper itself, it links clearly to the COM-B model. And they say that in some of their conclusions, that you can then use this, I think, and apply the findings to the COM-B model. So there was a really natural fit between the vaccine questionnaire questions that we ended up taking on board and the design that we used for the qualitative study. When it comes to the development of the qualitative instruments, we did a pretty thorough evidence review, which you can find on the Digital Square website, or I think for Drive Demand, maybe someone can put it in the chat. And we identified a number of different indicators in each of the COM-B levels and used that to inform both the development of the focus group discussion tool, as well as the card sorting exercise that we used to prioritize barriers. Any further questions?
I'll just
I
wait.
suppose not.
Yeah, maybe one more minute just to make sure there's no further questions. But thank you so much, Rowan and the Busara team for presenting on this and all of your hard work throughout this project.
Thanks everybody for attending. Well appreciated.
Great. Well, with that, thank you all, and we'll conclude the webinar. Have a great rest of your day.